and on the behalf of Indian Chess Society, Secretary Indian Chess Society, National India, I am bringing you today a very innovative new way of learning in the critical care area for the respiratory physicians. It's for all of you. Whether you are a respiratory physician, you are a student of MD or DNB or a DTCD or a DM, or you are a young physician who's practicing and looking after the intensive care unit. It's a learning which is going on an OSCE based, which has been primarily brought forward to you with the brainchild of Dr. Dhruv Chaudhary. This initiative is going to be there on the first Sunday of every month at 11 a.m. So we are going to meet on every Sunday, first Sunday of the month, 11 a.m. and it's a 2 hours program. And as I told you, brainchild is Dr. Dhruv Chaudhary, who is going to take this program forward as he has designed it. And I'm very happy that our knowledge partner, Glenn, has helped us, the Indian Chess Society 2023, to bring this program to all our loving students, as well as senior residents and other people who are related to respiratory and critical care medicine. Over to Dr. Dhruv Chaudhary.
Thank you, Dr. Deepak, and for giving us an opportunity. In fact, he called me, it's a brainchild, it is his brainchild. You said we need to do something for the respiratory critical care medicine. And who can be better than Dr. Rajesh Chawla to help us in guiding it? And then we tried that we should have one mentor, senior, and another our colleague. So the combination works and the baton can be safely exchanged. So in this process, we decided that the senior mentor for us today in this is Dr. Rajesh Chawla, who has been very eminent, has been past president of Indian Society of Critical Care Medicine, and has written books and also been responsible for the very famous and successful 4C course of Indian Society of Critical Care Medicine. Dr. Gyanendra Agarwal is a young colleague of ours who is also postdoctoral fellow. Along with it, we thought that there should also be that a host needs to be younger people because they know the pulse. They know what are the practice points which are there. And as a guidance, as a mentors, we can actually help them going up. And for that, none other than Dr. Manjunath, who is working at Manipal, who is DM in pulmonary critical care, and along with it, Dr. Girish Agarwal will be joining us later in subsequent courses. So we are going to have a full 1 year of this program. As Dr. Talwar told you, the first Sunday of every month, we will be doing it for 2 hours, and it is meant for all the respiratory physicians, all the internal medicine people, and also open to our colleagues from critical care anesthesia, because knowledge always grows with the sharing. With these things, we have tried to make it a OSCE because now the pattern is changing, teaching is changing, and now National Medical Council and National Board of Examination is putting a lot of emphasis on objective, subjective, clinical examination so that bias goes away from evaluation. It also helps us in creating standard operating procedures. And my dear friends, it is available right now, YouTube Live, Facebook Live, and Twitter. And you will also be keeping these things in archive of Indian Chess Society. With these things, now I hand it over to Dr. Manjunath. He will carry forward the proceedings and will continue to be the host anchor in all the 12 episodes. Dr. Manjunath, please. Manju, you are mute.
Thank you, sir. Thank you for the organizers for having given this great opportunity to us to start this module on respiratory and critical care medicine, which will be divided into 12 different parts. We will start from approach to respiratory failure today, wherein Dr. Aman Ahuja, who is a final year DM resident at PGMS Rohtak, will be presenting the case, and Dr. Rajesh Chawla and Dr. Gyanendra Agarwal will be our expert panelists. Now, Dr. Rajesh Chawla needs no introduction, as we all know that he has been a pioneer in his in the field of respiratory and critical care, and I'll just
continue, Dr. Manjunath.
I'm trying to share the screen, sir. 1 second.
No, it's okay.
So we know that he is the senior consultant of respiratory medicine critical care in the Indraprastha Apollo Hospital, Delhi. He has been a past president of Indian Society of Critical Care Medicine, past president of National College of Chest Physicians, and a national coordinator for critical care infectious diseases course. He is also the national coordinator for comprehensive critical care course, chancellor of the Indian College of Critical Care Medicine between 2014 and 2016. So with his vast experience, he will be guiding us in our OSCE based case approach today. And along with him, we have Dr. Gyanendra Agarwal, uh, who is who is the senior consultant and presently working as director of respiratory and critical care medicine in JP Hospital, Noida. His areas of interest are respiratory critical care medicine, ARDS and difficult ventilation, chest radiology, pulmonary embolism, and interventional pulmonology. And he has been part of many conferences guiding the younger generation through their quest for knowledge. So today we will start this case presentation. I will request Dr. Aman Ahuja to start the presentation, and in between we will ask our panelists to give their expert opinions. Dr. Aman, please.
With the approach to the acute respiratory failure. I'll start with my first case. A 42-year-old gentleman presented to the emergency with the chief complaint of fever for past 5 days, dry cough for past 5 days, and breathlessness for past 2 days. He's a never smoker and he's a hypertensive on tablet telmisartan. The fever was documented in range of 99 to 101 degree Fahrenheit, associated with chills, no rigors, no specific pattern, and was relieved with medication prescribed by local physician. Cough was insidious in onset, gradually progressive, dry, with no diurnal variation. Shortness of breath was insidious in onset. It was progressive. Initially, it was only when he used to go to washroom, and later on, even at rest, he was feeling breathlessness. There was no associated sinonasal symptom, no associated change of smell or taste, no associated wheezing or hemoptysis, no history of any orthopnea or paroxysmal nocturnal dyspnea. On examination, his vitals were pulse of 126 per minute in right radial artery, good volume, no radial radiofemoral delay. BP was 140 by 86 millimeter of mercury in sitting position. Respiratory rate was 28 per minute with use of accessory muscles. Saturation was 85% on room air. There was no pallor, clubbing, cyanosis, edema. JVP was not visible. And on chest examination, there was diffuse bilateral mid to late inspiratory fine crackles. Cardiovascular examination and rest of the systemic examination was within normal limits. So our first question is, how to define respiratory failure and what are the signs and symptoms of respiratory failure?
May I?
Yes, sir.
So respiratory failure obviously means when the respiratory system is not able to meet the demands which is supposed to do. And what does respiratory system basically means to do? It is primarily the gas exchange which is meant to us. So if the gas exchange is affected, like the intake of oxygen, which leads to hypoxemia or hypoxia, with or without hypercarbia, that leads to respiratory failure. So hypoxemia means if the oxygen level in the bloodstream is low, but hypoxia means if the oxygen is low at the tissue level. So there is some difference, and they not always go hand in hand. Of course, in most of the patients, they will go hand in hand, but in some patients, there can be exceptions, and we'll come to it in a little while also. So that is respiratory failure. And broadly, there are multiple types of respiratory failure. I'm sure we are coming to it in a little while.
Yes, sir. So the definition is pretty much described by the sir. Its respiratory failure is a syndrome in which respiratory system fails to maintain an adequate gas exchange during rest or during exercise, resulting in hypoxemia, which may or may not be with concomitant hypercapnia. So, symptoms of respiratory failure. Patients may present with dyspnea, palpitation, confusion, tremors, diaphoresis, or agitation. The signs of respiratory failure. In early phase, patient may have tachypnea, tachycardia with hypertension, but on prolonged hypoxemia, later on patient may land up in bradycardia or hypotension also. Some of the warning sign in respiratory failure is presence of cyanosis, use of accessory muscles of respiration, gasping respiration, or presence of flapping tremor or hysterexis. There may be alternate diagnosis also, but these are telltale signs of respiratory failure. So, various causes of respiratory failure can be described, starting from the brain stem where the respiration is initiated. Any sedative or narcotic poisoning or overdose can cause respiratory system depression and lead to respiratory failure. And any coming on to the respiratory system, it's the starting from the airway, impaction of any foreign body, any laryngospasm or tracheomalacia may lead to respiratory failure. After airway, we have obstructive airway diseases leading to respiratory failure. Then moving on to parenchyma, we have infections, pneumonia, pulmonary edema, fibrosis, and ARDS leading to respiratory failure. The contributory factor, other causes of respiratory failure may be vascular origin, that is pulmonary vasculature, severe pulmonary hypertension, pulmonary embolism causing respiratory failure, or it may be extra parenchymal, that is pleural effusion, massive pleural effusion leading to respiratory failures. Apart from the core respiratory system, there can be musculoskeletal system leading to respiratory failure, maybe due to congenital or acquired deformities in form of kyphoscoliosis, neuromuscular junction or diseases, any rib fracture or Guillain-Barré syndrome or spinal cord syndrome. All these causes can lead to respiratory failure. So coming on,
hold on. Whenever you see, you cannot take a respiratory failure is not a domain only presenting to a chest physician. You must understand whenever a patient has respiratory failure, whatever symptoms and sign you describe, they are only of hypoxemia or hypercarbia or maybe dyspnea, which is present in more. But one of the major reasons which we have patients getting admitted to the ICU, all through COVID, we had the ARDS. Probably that was a pulmonary cause of respiratory failure. Extra pulmonary diseases causing ARDS, that's also a very large chunk. So whenever you talk of symptoms and sign of respiratory failure, symptoms of primary illness, like a patient who has a pain abdomen in the upper part radiating to the back, he could be having a pancreatitis, which could result in ARDS. Bone fractures can result, massive transfusion can result, meningitis, abscess in the abdomen, abscess anywhere in the body. I mean, there are multiple causes which can result. So when you describe an approach to a respiratory failure, the symptoms of the primary illness resulting in respiratory failure and signs of that which is maybe pulmonary or extrapulmonary, and similarly the signs. Because, when you approach a patient, you do not approach a patient just because you have to correct the oxygen and you have to correct the carbon dioxide. Unless you lay stress, all the students who are watching this, basic reason why the respiratory failure has occurred must be looked into. If you do not take care of the cause of respiratory failure, whether it's pneumonia, whether it's a Guillain-Barré syndrome, let's say if it is a Guillain-Barré syndrome and you're not diagnosed, you ventilated, you made your guesses well, but you've not given the immunoglobulins or you've not looked at the plasmapheresis, this patient respiratory failure is not going to get better. So it is very important when you approach the primary illness must be given in your writings, in your discussions, that whenever you investigate also, you need to investigate the primary illness and the respiratory failure. I mean, the gases and the other thing which are specific for respiratory failure. All these could be relevant in a patient who's got a pulmonary reason for respiratory failure. But a lot of patients, particularly patients getting admitted to the ICU, they have a lot of extra pulmonary reasons also for the respiratory failure. Go ahead.
So
please.
for the benefit of, sorry, yeah.
Gyanendra, I'm just adding, that is why we call it
Yes.
as a syndrome. And respiratory failure may be, as Dr. Chawla said, primarily a respiratory issue, or it may be a part and parcel of involvement of multi-organ dysfunction as a consequence of outside insult, and then the respiratory system getting secondary involvement. In the terms of simplicity, for the students, I would like to add is, remember two things. First is, what is the process of ventilation and breathing? And second, what is the process of gas exchange? So anything which can interfere with the process of breathing, starting right from the central nervous system, going through the medulla oblongata of the respiratory systems, then through your 440-watt cable, that is the spinal cord, and the branches which are moving out, that is the nerves, and there then the neuromuscular junctions and the skeleton on which they attach, muscle as well as the ribs, anything which can come and cause a problem and respiratory failure. On the other hand, when you see a problem with the breathing in terms of gas exchange, what Dr. Chawla said is very true. You may have a pancreatitis, you may have a sepsis at somewhere else. There may be another lesions which have happened, like you have a transfusion, massive. They all can contribute, and that comes under the syndrome of ARDS to a very large extent. But nevertheless, you must remember that if we go by, and then the third thing in the breathing comes up the airways through which the gas supply comes in. So anything which is related with the breathing is ventilation, which is described by the hypercapnia, and anything which is associated with the gas exchange predominantly comes up with hypoxemia, and hypercapnia is a spin-off as a consequence thereof. Gyanendra, please.
So just a short, quick comment, sir, for the benefit of our residents. The common causes of respiratory failure which we encounter in our clinical practice are, one is pulmonary edema, which is mostly cardiogenic pulmonary edema, I mean. It could be non-cardiogenic, which is ARDS. Second is pneumothorax. Third, as rightly said by Aman, large pleural effusion. Before that, I would say pneumonia. And then, of course, exacerbation of COPD or maybe asthma. So these are 5 commonest causes of respiratory failure which are encountered in clinical practice. And it has been published that if we take care of these, or if we keep these 5 causes in our mind, we'll not miss more than 95% of patients who presents to emergency.
Yes, Aman, please continue.
So the patient was evaluated, the index case, and arterial blood gas and chest X-ray was done. The arterial blood gas showed pH of 7.48 with PCO2 of 22.9 and PO2 of 51.8 and bicarb of 23. These findings are suggestive of respiratory alkalosis with hypoxemia and increased lactate. The PF ratio calculated on presentation was 162. The chest radiograph, it is showing inhomogeneous opacities in the left mid and lower zone and in the right lower zone. So now, how do we describe the type of respiratory failure?
So this patient primarily has hypoxemia, and as you rightly said, the PF ratio, the PO2 by FiO2 ratio is very less. If it is less than 300, then it is called hypoxemia. Or if we have a person who is breathing on room air, the PO2 is less than 80, that leads to mild hypoxemia. If it is less than 60 millimeters of mercury, it is moderate hypoxemia. And if it is less than 40, that is called as severe hypoxemia. A rough calculation of PF, I mean, not exactly F here, but if a patient is on oxygen flow therapy, and then if we check PaO2, if it is less than 5 times the oxygen flow or FiO2, that approximately leads to the hypoxemia. So that also indicates, but the best value which we can have, as you have shown, Aman, is PF ratio. And if it is less than 200, then definitely it amounts for moderate ARDS range. So this patient primarily has type 1 respiratory failure, which accounts for the hypoxemia per se. But then if the patient has associated hypercarbia, which can be there in certain situations, then it is called as hypercapnic respiratory failure, or it is also called as ventilatory failure, or it is also called as type 2 respiratory failure. There are other causes of respiratory failure, more so for theoretical purposes, type 3 and type 4. Type 3 is mainly seen in perioperative patients who come from OTs to our ICUs, mainly because of basal atelectasis. And most of these patients do well on chest physiotherapy, mobilization, adequate analgesia. Type 4 respiratory failure occurs because of hypoperfusion of respiratory muscles, and it occurs mostly in patients who have any kind of shock, be it septic shock or even cardiogenic shock. So that is called type 4 hypoxemia. So our patient has type 1 respiratory failure, primarily hypoxemia, and I would say it was severe hypoxemia in moderate ARDS range. This patient also has the fever, short, acute history, bilateral ground glass opacities. So the commonest differential diagnosis which comes to my mind would be some sort of viral pneumonia which has occurred in these patients. But then yes, we'll also keep certain other differential diagnoses in our clinical scenario. Dr. Chawla, sir, if you have to add.
No, that's okay. Go ahead. So what is the role of pulse oximetry in respiratory failure, and how to approach type 1 respiratory failure? Aman, go ahead, please.
Yes, sir. So pulse oximetry has a very important role in the decision making and the management of the respiratory failure. It will give a real-time, non-invasive measurement of oxygen saturation. It is based on the two wavelength, that is 616 nm of red light and infrared light. The oxygenated blood absorb more of an infrared light, and the deoxygenated blood absorb more of a red light. And this is detected by sensor, and based on that, we'll get a real-time assessment of the oxygenation. The issue with pulse oximetry, it is quite reliable, but when the saturation falls between below 70%, the accuracy decreases, and it may give.
The accuracy is also less if person is hypotensive.
Yes,
because in hypotension, cold extremities, many a times, people come to your OPDs with a finger that my saturation, and you warm it up, it is normal. So these are also, and previously they used to say the nail polish also, but somehow in some, it is better to take pulse oximetry without this. What is the hyperbilirubinemia? Can it change the oximetry, Dr.
I don't think, sir, it will change.
Gyanendra, you have to say anything on this? Nail polish and hyperbilirubinemia, because they also give a false in some patients.
Especially if somebody has put a red nail polish, it can interfere with the UV light. So therefore, always it is recommended that two things are important, because pulse oximetry, if you see, there is written also PI, perfusion index. That is what you will see. It comes up besides your SpO2 and pulse rate. So perfusion has to be adequate before this pulse oximetry can pick it up. One. Secondly, which is, as you have very rightly pointed out, that nail polish ideally should not be there because it can interface with the UV light, because it is specifically that it interfaces with the red one, and you can have a difficulty in calculating the saturations too. Third thing, as he has pointed out in the pulse oximetry, it is very important, sir, is that what sort of a hemoglobinemia, like quite often if you're finding that there is an 84%, 85% fixed value is coming up, and then along with you, there is a bit of a gray hue, think in terms of methemoglobinemia, and there, when you do an arterial SaO2, that is arterial saturation, the saturation gap comes up and can give you a clue towards the cause of hypoxemia secondary to methemoglobinemia. I absolutely agree with you. And third thing, which is another thing from the point of measurement is concerned, which residents must know. Normally we put our index finger. Ideal recommendation is you are actually the middle finger. Reason for this is the dual supply. So because of the dual supply circulation and this, you can have the surety that observation is right. One. Second, which you need to look at is when you put a pulse oximeter, keep at least for a 30 seconds, preferably a minimum, preferably a minute. So let it stabilize. And as Dr. Chawla very rightly pointed out, these are the clinical pitfalls we see with the pulse oximeters.
And the other thing is, hyperbilirubinemia used to be considered. And now there are a lot of studies done that hyperbilirubinemia does not interfere. That's why I asked, because it used to be considered. Now they say that it does not interfere with the pulse oximeter.
And sir, another important thing which the COVID taught us was in the pulse oximetry, I hope you and Gyanendra will agree with me, and Manju also, is that in the Western data, they say the color of the skin and the pigmentation is making a difference. And in the Western world, Caucasians have been usually white males or white women, whereas in the black men and women, they found out that it was giving a falsely high values, leading on to less picking up of hypoxemia or late picking up of hypoxemia. These are the evidence-based data which have come into publication.
Sir, just to add on to what is being discussed, one more challenging thing we face in day-to-day life is when the patient is having fever and shivering or he is having tremors. There, to get the accurate pulse oximetry becomes a huge challenge, and that we face day in, day out. And sometimes when we have our ILD patients who have a background history of some skin disorders like systemic sclerosis or something like that, then also it becomes a big challenge. I think shivering is one thing which we routinely experience in our day-to-day practice.
So hypoperfusion because of any cause. It can be because of Raynaud's phenomena or because of hypotension. The reverse of methemoglobinemia can also occur, wherein the PaO2 is low and SpO2 is normal or high. It can occur in patients who have a lot of leukocytosis or high platelet count because of larceny. So that is also one clinical scenario which can happen.
And, carboxyhemoglobin, in spite of PaO2 being low, it gives a normal. And methemoglobinemia gives a low in spite of PaO2 being normal. So these should also be known. So that's why ABG is very important, particularly in patients where you have the carbon monoxide poisoning or patients having methemoglobinemia. I mean, the ABG once a day, that's why in a critically ill patient is always advised, so that you correlate with your saturation. And if you find it is not, then you need to look for the cause of it.
Very true, sir. And that is what, my dear students, what Dr. Chawla and Dr. Gyanendra and Dr. Manjunath said is, never ever forget the clinical context. And when you're using any tool to support you for the clinical decision making, always need to know the both advantages for which you are using and also the pitfalls, so that you are not falsely trapped into a false sense of well-being, or there should not be an overreaction, sometimes creating to unnecessary treatment.
Please go ahead.
I would like to add that earlier we used to have Berlin definition of ARDS, which defined ARDS primarily on the PF ratio, and it requires an ABG to diagnose the ARDS. Later on, Kigali's modification was advised in setting which don't have the facilities. Now the new definition of ARDS has come, and it is defining ARDS based on SF ratio. So this new global definition of ARDS, in this we can diagnose hypoxemia if SF ratio is less than 315 with SpO2 of 97. So without arterial blood gas also, we can now diagnose the ARDS if other criteria are fulfilled. Coming on to approach to type 1 respiratory failure. So hypoxemic respiratory failure, once we do arterial blood gas, we have to calculate alveolar arterial gradient. And based on alveolar arterial gradient, if it is normal, primarily it suggests alveolar hypoventilation or an decreased FiO2. And if it is increased, it may be because of shunting, VQ mismatch, or diffusion limitation. So how do we calculate alveolar arterial gradient?
This is just hold on, Raman. I think this is a very important slide in terms of diagnostics of the respiratory failure. So whether it is type 1, type 2, what you look at it, even the patients who have got an alveolar primary hypertension, decrease FiO2, anytime you find, always make it a mandatory to calculate alveolar arterial gradient, because it will guide you. And as far as the increase, you should always look at it VQ mismatch as the major cause. Shunt is one extreme, dead space ventilation is another extreme, and obviously the diffusion limitation comes in between. Therefore, whenever it is there, remember that Shunt will be defined when it will be oxygen-resistant hypoxia. Remember, at the basic bedside. Rest of the definitions, you can do it, but from the clinical perspective, if you give oxygen, it does not improve, then it is a shunt. With these remarks, now it is important for us to calculate alveolar arterial gradient. How do we calculate it? I think Aman will let us know.
So coming on to alveolar arterial gradient, it measures the difference between the oxygen concentration in the alveoli and in the arterial system. Ideal system, there should not be any gradient, but because there is no complete diffusion, gradient is there. And this occurs due to physiological VQ mismatch. Normal AA gradient, if we calculate according to age, it is calculated as age plus 10 divided by 4. So for calculating alveolar arterial gradient, we need to know alveolar gas equation. So the alveolar oxygen concentration depends on the partial pressure of the partial pressure and the FiO2 given, and the partial pressure of carbon dioxide and respiratory quotient. So the partial pressure of is the atmospheric pressure minus the partial pressure of the water vapor. The atmospheric pressure is 760 millimeter of mercury, and water pressure is around 45 millimeter of mercury. So it gives us 715 as a value, and it is multiplied with the FiO2 delivered according to the system patient is given oxygen supplementation. PaCO2 will get from the arterial blood gas, and respiratory quotient for the mixed diet, we can take it as 0.8. So in the R patient, we applied the same. The patient was at room air, so FiO2 of 0.21, atmospheric pressure minus the vapor pressure, and PCO2 from the ABG is 22.9. So PaO2 we are calculating is 121.4, and what we can get from the ABG, that is the arterial oxygenation, that is 51.8. So the gradient becomes 69.6, and normal for the age would be 13. So the AA gradient is increased.
Just I will add, my dear friends, this is the accurate way of collection here. Sometimes now we all have smartphones. We can always calculate, or we can have the formulas which are available with various apps which are on your mobile phone. That can be one way. But it is always good to know the physiology. Here, I simply say what I practice is, and I hope Dr. Chawla and Dr. Gyanendra will agree with me, because 760 is the pressure at the sea level. We are nearly around what height of 230, 250 meters from the sea level. So practically it turns out to be 746. So from the practical bedside calculation purposes, what I do is, and what we have been taught and what we have been practicing is that you take 0.21 is the FiO2, multiply by 700, because that is what it will be. 747 minus roughly comes out 45 or 46, you take, it turns out to be around 700. So 0.21 into 700 minus PaCO2, which we have measured, divided by 0.8. So if I calculate here itself also, it will, to me, it will turning out to be 140. Then you will also, PaCO2 is 22. And here, if you see it, it's so closely mimicking it. So you calculate from where the alveolar oxygen, and then you gradually come on the bedside, you can calculate that. But nevertheless, what Aman has shown, this is the right way. Most important for us to know is that which oxygen at the bottom line we are using up as an FiO2, because a lot of these things will depend upon in terms of calculation, and on the basis of there will be a change in the gradient. So you calculate the normal arterial gradient as 42 plus 10/4. That is how we go ahead. That is the age plus 10/4, or you can say plus 2.5.
The other thing is, Dr. Dhruv, if your FiO2 is not correct, many patients are on a mask, and, this is the little limitation of the alveolar arterial gradient. That's why the best is when the patient arrives, if you could take a ABG sample before starting oxygen, that will be the exactly correct. But then this 0.21 can definitely, little increase can give you a false value. This is one of the limitations. You have to be correct in the calculating the FiO2 in that patients.
Sir, for that, there are calendars. Actually, you have that normograms available on the basis of which we can calculate. That's what I'm saying. Now, all the residents today, everybody today has with them the smartphones. So that has made the life much easier. But what you are saying is very true. And that is the challenge we used to face earlier. But nevertheless, there are normograms. So compare it with that normogram, because if anything which is going beyond that is abnormal. Gyanendra, anything to add?
No, sir, I would agree. And mostly we use this simple calculation of 150 minus PaCO2 into 5/4. So that gives us a good amount of estimate about AA gradient. And calculating AA gradient definitely adds up to some differential diagnosis. Because if the patient has primarily hypercarbia with a normal AA gradient, we know it's only hypoventilation. It's not the respiratory system, it's CNS which is involved. And if the AA gradient is high, then definitely there's something in the respiratory system locally we must focus more so. So this will certainly, and this is not difficult, it's easy. We may not be very accurate always, but it gives us a rough idea and helps in differential diagnosis.
You know,
one more point which I want to add is, and it is not in all the patients that we will have a single disease process, pathological process. That is also one of the challenge that just we can't just stick on. We have to take into consideration other clinical parameters and the overall picture of the patient, because many a times we will have mixed disorders. So,
you know, I will share, because this really changed my life, the way I looked at it. The AaO2 is very important. You know, I'll give you an example. A lady came with hyperventilation, and this was long back, 25 years, 30 years ago. And when you examined, the chest was normal and the saturation was showing all right. And everybody said that this is a psychogenic side. We sent her home. She again came the next day with a similar complaint. And like, you know, that time nebulizer and all those things were not there, because the saturation was showing normal and the ABG was also done. It was falling 80 something, but nobody calculated the AO2 gradient in that. And third time she came and she died. You know, and then we looked at that time, the AO2 gradient was very high in that patient's, because, you know, she was hyperventilating and probably she had, then I took a history and she was on oral contraceptive, probably she was having pulmonary embolism. That time, all these concepts which we have not there. And then when I calculated, the AO2 gradient was very high. So, you know, before saying anybody that it is psychogenic, please do calculate the AO2 gradient, because it will also give you that there is hypoxemia. So this has a lot of importance. Most of us either see the saturation or the ABG and regard it as the normal, because patient who is hyperventilating, PO2 could be extremely high actually in a young hyperventilating female. So if you calculate the AO2 gradient, it can really tell you whether there is one of these VQ mismatch, diffusion or shunt. These are the three reasons which cause the high AO2 gradient. So it's very important and it is not practiced. And we as a pulmonologist and as a physician must practice this in our day-to-day practice.
Very well said, sir. I think it could not be a better explained as you have done it. Aman, next, please. Sir.
Next is how to investigate patients with an acute respiratory failure.
Can I interrupt, sir? Just before we move on to the investigation,
yes, please.
We have two questions from the participants, which I will ask our expert panel to answer. The first question, sir, is can polycythemia affect pulse oximetry readings?
Not really. I have not heard of polycythemia, because it could, if it is too much, if it is affecting perfusion, then it could affect. But otherwise, polycythemia, I have not heard that it does affect the oximetry.
If the leukocyte count is very high, like which can occur in patients who have leukemia, or if the platelet count is very high, that can affect. Again, the mechanism is same.
That is called as a larcency. That's
Larceny.
Because they eat away a lot of things and they cause the penalization. Okay? So that is same is true for anemia also. You see, we need to look at it. Saturation is amount, because hemoglobin has it is the place which holds the oxygen. Therefore, you will see a difference going between arteriovenous. Difference will be high. But when you look at the pulse oximetry as such of the arterial side, it doesn't make a difference. But when you will calculate oxygen carrying capacity of the blood in the arterial venous, because body extracts a lot of oxygen to fulfill its demand because supply is less. That is where the differentials go. It's only when extremes of anemia happens this you will see that the counterpoint I'm talking about, hypoxemia A. B, as far as the polycythemia is concerned, but in these cases, we don't see as much of a difference as far as each patient is concerned. Dusky cyanosis is though known because when you are having the relative amount of reduced hemoglobin also goes up. That is why, plus there is a sluggishness because of altered rheology, altered viscosity that can happen. But as such, saturation will not be effective. I hope it answers the question.
Absolutely, sir. I think we have the answer for the question from our experts. And one more question, which we also almost come across every day is venous blood gas. Is it helpful if you are not able to obtain an arterial blood gas sample? That is the question, sir.
So venous blood gas may be helpful to see the pH and the PaCO2, PaCO2. Again, which would be pH will be little less in the venous and PaCO2 will be little high. But then if we want to see the PaO2, then it is quite unreliable in the venous sample. So it is always advised to correlate your SpO2 and PaO2 values. And if the difference is less than 4, then it is mostly the ABG and it's not the venous blood gas. But if you are targeting a patient, if you are treating a patient with respiratory failure, please go ahead with ABG. Taking ABG is not at all difficult.
But of late, because of the multiple pricking, venous ABG has picked up. We did one DM dissertation of Dr. Diksha, and we looked at it and we found out that there was a significant, we looked at end-tidal CO2, we looked at venous CO2, we also looked at arterial CO2. We found out that as far as the hypercarbia is concerned, it was very well correlated. But we always find venous and arterial, there is a gap, what you call as a VA gap. In this case, we know arterial carbon dioxide gap, which should be around about 4 to 5. And then you can also have a gap between the venous and the end-tidal CO2. So they can represent, but you should know the basic at that point of time, what is the basal PA2 values or the basal gases value at the level when you do the of the arterial blood gas. Then you take a comparison and then you move ahead with it. So it can be people are trying to be less invasive and try to replace it. It cannot fully replace it, but partly it has done that. And I do agree what Gyanendra said, but nevertheless, we have once patient is stable, we have been following much more with the venous than arterial, and that's what is being practiced today. Dr. Chawla, anything to comment?
Venous is only good if you want to see the pH and bicarb, because the pH is about 0.02 to 0.04 lower than the arterial pH, and bicarb is only 1 to 2 milliequivalent higher than the arterial bicarb. So it gives a very good information about the metabolic acidosis or alkalosis. But PaO2 is 36.9. There could be difference of, there are studies which have shown that 36.9 lower in the venous and greater in arterial. And PCO2 also, their studies have seen their wide variability. And they say that you should not rely on PCO2 on the venous because they had found difference of 10 to 2 in various studies. So for pH and bicarb, venous is very good, because many a time you want to know that whether the person has acidosis or metabolic acidosis, then it is because bicarb and pH hardly any difference. But the PaO2, there could be difference of up to 36.9, and the PCO2 also, because venous is always higher, and they have found the difference from 2 to 10. So you should not rely. If there is any doubt, please repeat. And as a pulmonologist, you should at least know taking an ABG sample. That's what, and that you should get.
We combine usually with SpO2 and do it because whenever the CO2 levels shoot up, it's an acid. So it starts reflecting alteration in terms of your pH and bicarbonate. So that way, pH to begin with and bicarbonate later on. So it's a combination which you will like to use it, but the gold standard continues to be ABG, we will be having one full session on blood gases in the coming, out of those 12, one is on blood gases. So that we will be following it up in subsequent webinars. Next, please.
So just a minute for the benefit of our resident colleagues. We have discussed the causes of respiratory failure, but just few common causes of type 2 respiratory failure before we proceed, because that is one common scenario which is encountered in our practice. So the commonest cause is COPD, acute exacerbation. For that matter, any other structural lung disease, which is advanced structural lung disease, be it ILD or bronchiectasis, that can also present with primarily type 2 respiratory failure. The second or the third most important causes are the hypoventilation syndrome, and in this world we are seeing more about the obesity hypoventilation
And
syndrome.
we will be subsequently taking up in the second case. So let's move ahead with it.
Okay.
So that's what we looked at the causes. That's what I said. The breathing component comes up with the ventilation, and the ventilation is defined in terms of carbon dioxide, whereas the gas exchange dominantly explained on the basis of oxygen and with supplemented by carbon dioxide. So we will be taking it up, Dr. Gyanendra, right now. Yes, investigations for acute.
So
please.
next question will be, what all investigation would like for an patient who present us with acute respiratory failure after getting an ABG and chest X-ray? So we may have blood investigation ranging from complete blood count, renal function, D-dimer, NT-proBNP, and cardiac enzyme if we have suspicion of cardiac illness or cardiogenic pulmonary edema. Radiology, chest X-ray is mandatory, and wherever available, the lung ultrasound may be used, and CT scan in some certain cases, which we'll discuss subsequently. And other investigation like ECG, if patient is expectorating, then sputum microscopy and culture, viral PCR for COVID or influenza, and multiplex PCR if available.
Chawla, sir, any comments on these things? Sir?
Basically the primary investigate, one is of respiratory failure, the other is the primary reason. You have to get, if it's a pneumonia, all this what you've shown is all right. If it's an extra pulmonary, you need to send investigation for that. And that's why whenever you approach to respiratory failure, you must examine as a physician the whole patients and then be precise on what would give the maximum information. Now as the time is passing, we have a lot of tests, and a lot of tests like the procalcitonin and all these are very misused. So you should be, because you see, we are in a country where although the insurance has come up, but you should be very specific that why you want, just do not write CBC, KFT, LFT like that, write down. You need to know why you want to know. Let's say like complete blood count, you want to know whether what is his hemoglobin level, what is TLC's high. Renal functions are very important, because whether it's causing multi-organ failure or this patient, if goes for a CT scan with contrast, ABG will give you information about D-dimer because you're thinking of pulmonary embolism, and NT-proBNP, you want to differentiate in pulmonary edema. But if you're very clear it is pulmonary, there is a consolidation, there is no need of getting NT-proBNP. Similarly, there is no need of D-dimer if there is a pneumonia visible. Cardiac enzyme not required if the pneumonia is visible. This patient had a respiratory, so all these three are not required. You need to get all the first four. Similarly, chest X-ray, definitely. Lung ultrasound, you must. ECG, baseline. Mostly a critically ill patient should have an ECG. And the lung ultrasound, usually, as the time passes, all pulmonologists, intensivists, they are getting expert in having a basic cardiac examination also, because that helps you to differentiate. Many times when a critically ill patient, they're not very clear whether you're dealing with respiratory, cardiac, or both. Many times person has a viral illness, but there is a myocarditis. So having all this 2D echo would also be one of the important investigation if you have the inclination that there could be an element of cardiac. And then these sputum microscoping and culture, viral PCR, of course, is if there is a doubt that it is a viral illness. Multiplex PCR, I'll hold on to that because I will only get if I have not reached at a diagnosis. Or, if you feel that I would require later, so then you can get it done, because all these are extremely expensive tests. And then investigation if it was an extrapulmonary. So minimal possible investigation. You should always have a mind why you want that test. What is you are expecting pre-test diagnosis or pre-test probability of any. You should become like that, because just ordering like that, I somehow don't believe in that.
Absolutely agree with you. And underlying clinical condition, as I said in the beginning, must not be ever be forgotten. One. Similarly, I do agree with complete blood counts, renal function, arterial blood gases. Usually we do in all cases of respiratory failure, one diagnosis is there. D-dimer has some value in terms of it. One, it is important if you're suspecting a probability, as Dr. Chawla said, is high. If you're thinking in terms of pulmonary embolism, it has a very high negative predictive value. But as you have all of us seen during COVID, the values are very high in large number of cases, which was telling us endothelial inflammation. So that does not mean because the multiple inflammatory pathways are opened up. So D-dimer can tell you in terms indirect evidence of inflammation. Anti-pro-BNP and cardiac enzymes, if somebody has a kidney dysfunction, you can have a false, in particular with anti-pro-BNP, false results. Cardiac enzymes, if I'm suspecting cardiac dysfunction, whether MI or myocarditis, as you rightly said. But I think, sir, what is important is with the chest X and lung ultrasound at the tertiary care centers is becoming available. As you rightly pointed out, it is important. And CT scan, I will consider only and only if I'm suspecting pulmonary embolism or there is an evidence of a diffuse alveolar hemorrhage, which we are not able to pick it up early. It can help you picking up early. Yes, there is a problem, but it will be in a selective case, not across the board. And multiple PCR and viral PCR, we have, because we are in a public sector, we have availability. The fundamental is what we need to know is, as viral illnesses, usually we are able to diagnose in a combination in terms of epidemiological diagnosis when a certain deluge is there. But in another importance of these multiplex molecular diagnostic tests without being expensive is a practical limitation. But another thing is they're extremely sensitive, so they cannot be used subsequently as a follow-up. So we use a multiplex PCR sometimes when the patient come to know the diagnosis. Like we diagnose a lot of influenza B this time, which was not earlier. We picked up metapneumoviruses, we picked up rhinoviruses and adenoviruses in adults as the cause. So it gives you some amount of comfort, and like strep pneumonia, we have picked up a lot. So they have advantage that it can help you channelizing the right choice of antibiotics. So it can be a diagnostic, it can be part of diagnostic AMR, if you ask me. Antimicrobial stewardship, diagnostic antimicrobial diagnostic stewardship review can be of help. But I do agree with Dr. Chawla, they are quite expensive and should only be used with the judiciously, with the clear-cut mind what you are looking at. And put a microscopic culture.
Another thing, just to add on to what you said, one should if you have a very high suspicion of pneumonia and chest X-ray is appearing normal, you must get a CT scan, because the sensitivity of detecting pneumonia, many a times we have detected pneumonia when there is a very subtle shadow, there's no shadow, and you get a CT scan and the sensitivity of CT scan is a little higher. If you have a really high suspicion of pneumonia in that way.
Gyanendra, anything to add?
No, I would agree with most of the points, but I'd like to re-emphasize the importance of lung ultrasound, especially in emergency, because that really helps in shortlisting the differential diagnosis. I do agree with Dr. Chawla, sir. In a subset of patients, CT scan is really helpful. For example, if a patient is having retrocardiac shadow, a pneumonia behind the heart, or sometimes to know about the ARDS mimics also. So in last 2 years, we have diagnosed about 8 patients of TB ARDS, which is a relatively rare entity presented with ARDS. But then unless we could have got CT, we could not have diagnosed TB as a cause of ARDS. Another thing, if the patient is having some opacity on the chest X-ray, it doesn't always mean that it is pneumonia. So an infarct or a localized hemorrhage or sometimes a mass can also present like this. So pulmonary embolism can be a surprise in these patients, especially if it is not having telltale signs or symptoms of pneumonia.
I agree basically with you, but nevertheless, I think fundamentals is that start with the basics, see to it. And when things are not fitting into it, then you go for the investigations like CT and other things. And also, I do agree with you that the sonography is redefining on the bedside the diagnostics of acute respiratory failure in terms of morphology and also in terms of helping us in probable etiology for that morphology. I think here we all do agree with it. And now let's move ahead with it. Another thing which I've seen is quite often, I'm seeing of late is with the more availability of bronchoscopy, a lot of people are doing it. My request is, unless it is specifically indicated, you have a foreign body, you have something else, then usually one should refrain without any support to going into the airway. Dr. Chawla, any comment on that?
I'll tell you my practice. When I started bronchoscopy, I used to do a lot of bronchoscopy, any shadow not responding. But as the time has passed, what I'm expecting, I always think, am I expecting TB? What I'm going to gain? If it's a pneumonia and I have started the antibiotics, I would wait that patient to respond. I would not go for bronchoscopy if he's not responding. And you always should have a reason. What you want to look for with the bronchoscopy. Just because there is a shadow, please don't do. And many a times I've seen harms being done by bronchoscopy, patient getting nosocomial, patient getting other complications. So you should have what you are looking at and what is your probable diagnosis, what you want to do with these samples and what you're thinking, then only do it.
Anindra?
Bronchoscopy, sir, again, hypoxemia is a relative contraindication for bronchoscopy. So I am dead against bronchoscopy in patients who come with acute respiratory failure till we have a certain indication for bronchoscopy. So I fully agree with Dr. Chawla, sir, that it's not going to help majority of the patients who present with acute respiratory failure, which we are talking today. Yes, the indications of bronchoscopy will be separate altogether, and I am sure in subsequent webinars, we'll be focusing more on that.
The reason I asked this particular question was because I've seen number of people doing it on day one itself. So the message from our side is that please don't do it unless it is specifically indicated, like you want to have a foreign body causing it. But again, there also it is rigid, which is a choice, then the fiber optic. But nevertheless, be careful. And what Dr. Chawla said, experience is telling us less is more. Am I right, sir? And let's move ahead.
One indication where I always perform in respiratory failure is an immunocompromised patient, a post-transplant patient. People where I know that they will not have the common organism. So there definitely we do it, and it has really helped many a times, not many a times, almost all the times we get PCP, we get CMV. There was a patient recently where I got the AFP positive, PCP positive, very high CMV, and that person had galactomannan also very high. He was on extensive immunosuppression. And because of that, he became so immunocompromised that and that we would not have, and that patient, we gave the treatment for everything, and we could make that patient survive.
Very well said, sir.
Immunocompromised patient, you should, if it is too clear, you think it's a PCP, but these are the patients, HIV, the post-transplant, and any other immunocompromised status where the odd organism, opportunistic organism, there you could do it. But otherwise, normal community-acquired pneumonia, it's not indicated, as Dr. Dhruv said.
Very well said, sir. Very well said. Aman, please.
Aman, wait, come back to the previous slide. There are a few questions pertaining to this particular slides. We will take up the questions now itself so that we are relating to their questions. One is, actually these questions are from different part of the world. The one question which is here is, when D-dimer should be done and what is the value of serial D-dimers?
D-dimer should only be done if you have a low probability of pulmonary embolism and you want to rule out pulmonary embolism. That's number one. Number two, because if you have a high probability, I will straight away, if I can do it, I'll do a CT pulmonary angio rather than wasting time on getting D-dimer. and low or maybe intermediate also if it is negative. But if it is positive and I have a suspicion of pulmonary embolism, then also I will go for CT pulmonary angio. Then the other indication is it is one of the inflammatory markers with CRP, ferritin, D dimers we've seen in viral. These are the two conditions I would do a D dimer. Otherwise, in a respiratory failure, I don't think any other. I mean, Dhruv or Gyanendra can add anything at it.
I think, sir, I agree with you. We saw in COVID that there was a strong evidence of pulmonary intravascular coagulopathy. There it was very high. That did not mean that this patient had actually pulmonary embolism. There was an in situ thrombosis because of endothelitis which was taking place. So see, that it is as Dr. Chawla said, I said earlier also, it can tell us endothelial inflammation. It is to rule out. It never proves pulmonary embolism. If it is negative, it consistently tells us, yes, gentlemen, think an alternate diagnosis. And what Dr. Chawla said, I will add to it. It is very important at the bedside is to do a duplex ultrasonography. Nearly 40 to 50% you will pick up if there is a very high suspicion of PE. And as he said, if there is a respiratory failure, there is a strong suspicion. I will go for a CT pulmonary angiography. And if I can have a venous section of that, which also can pick up the thrombosis in the pelvic and the other veins. So otherwise we don't do, and we don't follow it up with the sequential. Only thing is if you want to put it as like a CRP as a marker, then it is a different thing. But otherwise normal values have continuous or multiple times is no value. But yes, if it is extremely high, it tells you there is a significant endothelial inflammation is there. Nothing more.
What has happened is, just a second, what has happened is because of COVID, even now the D dimers values, and once the D dimer value is high, that patient serially and the doctor serially is following. Somehow, I don't feel that these have much value and giving anticoagulants in a patient who is mobile. But if patient is admitted, probably there you could give a prophylactic anticoagulants.
The indication becomes entirely different for prevention of thrombosis, but we don't treat it as such on the basis of D dimer alone, because D dimer can lead to falsely using of, because it's a part of inflammation of anticoagulation, and one has seen people going into catastrophic bleeding. Therefore, clinical context of the patient is key, A, and secondly, there is no value of a sequential D dimer unless and until you have no other value to look for the inflammation. If you have a CRP, we just followed it up. At best, to ensure it at the time of discharge, I will be denying it that we looked at it if they were very high to continue this patient on for another couple of weeks for the anticoagulation. But that we did initially. Later on, once we realized it is telling us inflammation, so we just followed with CRP. And we did not continue or didn't give the oral anticoagulation.
One more point.
What's the second question?
Just one more point. If you are getting D dimer, then always get quantitative D dimer. And there's something called as D dimer adjusted for age. If that is high, which means more than 4 times upper limit of normal, and in the right clinical context where the patient has radiological and clinical discorrelation as far as hypoxemia is concerned, then it is always worthwhile to get advanced investigations like CTPA.
Also, it is basically a part and parcel if you're suspecting DIC, or in females also, like we see continuously, especially pregnant females, you will see values will maybe falsely high. So there the value cutoff for the normal will be nearly 10 times to what we see. So we must, whatever the test we order, what Dr. Chawla said, we need to look at it, their indication, we need to look at their contraindications, and what are we expecting, why we want it. Therefore, when we are making these investigations, ordering these investigations, please look that into account. I think it answers most of the questions. What is the next question, Manju, quickly?
Yes, sir. Thank you for that. I think things are more clear on D dimer, when to use and how to use. One more question is regarding this multiplex PCR. Now, the person has a doubt that when the patient is already in an inflammatory phase of viral infection, do we really change our management depending on multiplex PCR tests?
You
That
see,
is the
on the basis of multiplex PCR, you don't change if your diagnosis is the same. It does change if you're finding, you see, multiplex PCR is not only for the viruses, it also looks at the bacteria. And we need to understand the interpretation. I give you an example. We used to think in terms of H influenza. We picked up a lot of H influenza and we modified our antibiotics and it worked because we found out that there was a very high level of drug resistance in H influenza. When we were sending our cultures, which were coming negative, but when we did the multiplex PCR, we picked up the organism. So it is not multiplex PCR does not simply means is that we are only looking for the viruses. That is only one part. You can pick up here the bacteria, typical, atypical, both, and then you can modify your treatment by and large because most of the time in pneumonia, we use both beta-lactam inhibitors plus macrolides. So the net result is that it is not picked up because feel that we are covering everything, which is true. That is why I use the word right in the beginning. If it's a virus, I will stop short of using antibiotics. And that's what we saw in COVID also, that procalcitonin levels are very low. So we never used antibiotics. So it can help you realizing whether you want an antiviral A, and secondly, whether you need to give an antibiotic or not, and what is the organism which you can pick it up. And another example of few of the multiplex PCRs like film array is, if they detect the organism, they tell you the pattern of drug resistance. So detection is one part. Then you need to look at the quantitative it because it is very sensitive. So it will not differentiate between colonizer and the infector. So there at that place, they have a qualitative value. Like for the film array, we go with 10 to the power 7. They call it as a bin copies. So if that is there, we use it accordingly. So it can tell if NDM is come up. I know I cannot use I cannot use carbapenems. If it is an oxide, it will tell me I'm dealing with ESBL. If I'm using WIM. So according to that, you can actually choose your antibiotics. But quite often, most of the time, like we are using as a part of diagnostic, as a part of one study, as a diagnostic AMS, and also later on in the wards, when we are having other issues in terms of making the diagnosis. And I'm amazed at looking at the step pneumonia, which we used to miss, and H influenza, and though these two particular, we picked it up. So looking at it, it can reduce the load of use of antibiotics right in the beginning by nearly 30 to 40% in pediatrics and adults. It has not to be shown because most of the time we prescribe by our habits. Dr. Chawla, anything else? So that
No, I think just let's continue because we'll be only able to do one case, I think.
So quickly, I'll just summarize how to differentiate between cardiogenic and non-cardiogenic pulmonary edema. So cardiogenic pulmonary edema, patient may have history of myocardial infarction or congestive heart failure prior to presentation. Patient presenting with pink frothy expectoration, peripheral edema, raised JVP, third heart sound or any murmur. On lab evaluation, we may find out raised cardiac enzymes, raised BNP, typically more than 100 picogram per ml, or raised NT-proBNP, that is more than 900 picogram per ml. And radiology, we can have increased in heart size, greater than normal vascular pedicle, inverted vascular distribution, and pleural effusion may be present, septal lines or curly B lines may be visible, and air bronchogram usually is against the cardiogenic edema. So this was our case. Patient had normal counts. Urea creatinine was borderline. COVID RT-PCR was negative. In a multiplex PCR, it showed influenza B positive, and rest of the examination was normal. So next question is, what is the role of ultrasound in acute respiratory failure? So we have now point of care ultrasound, which is performed and immediately interpreted by the bedside by the clinician himself. And this last new definition of ARDS that we discussed prior, it now says that even if we can demonstrate bilateral lung involvement by lung ultrasound, we can consider it as ARDS along with if X-ray is not done, even before X-ray, if we can pick it up, then also it can be included. And we have lung ultrasound in emergency blue protocol. I'm not discussing blue protocol, but I'll just quickly show some typical findings in lung ultrasound. So this is how it is done. The upper blue point and the lower blue point and the PLAPS point. These are the three locations where we will put the probe. And this is the most echogenic line that is moving is this is the pleura. And we can show it as this is the pleura, which is gliding. This is seen in the normal lung. And if we put a M mode on this, we can see that seashore sign, which is above, it is looking like a barcode. Then there is a pleural line, and below it is looking like grains of a seashore. So when this pleura is not moving and we put an M mode, we get a barcode sign. Normally we see B lines that is extending from pleura to till the end of the screen. The vertical lines, these are called as B lines. Normally we can see 2 B lines in a lung field, but whenever it is more than 2 B line in a single lung field, it is pathogenic. It may be because of pulmonary edema or pneumonia or an interstitial involvement. Some sign to define consolidation. So this is the hepatization, that is the lung is looking like more of a liver. Then we can see hyperechoic shadows, which may be dynamic. These are the air bronchogram, linear, and this. Then we can have anechoic or shadows, which is pleural effusion, which may or may not have septation. And if it may become infected or has blood in it, the echogenicity will increase and it may show finding like of a empyema and hemothorax. So this is how dynamic air bronchogram look like on lung ultrasound. So this we have already discussed, like the role of CT in acute respiratory failure. CT pulmonary angio, it's the gold standard to diagnose pulmonary embolism. Other situation where it should be considered is hypoxemia with a normal chest X-ray, massive hemopsis, clinical severity not explainable by the chest X-ray, and immunocompromised with an ambiguous finding on chest X-ray.
Go back.
Yes, sir.
All these they should be considered only if you are thinking of pulmonary embolism, because hypoxemia with normal chest X-ray can be pneumonia also. Hemoptysis can be if you have a high test probability and all these are also present, then the CT pulmonary angio is indicated. Not that if anybody who's got a hypoxemia with normal chest X-ray, if you have a very high, you're thinking that there is a pulmonary embolism. Similarly, if you're thinking and a patient has hemoptysis, there could be a pulmonary infarction. Similarly, clinical severity not explained by chest X-ray. Undiagnosed, unexplained hypoxemia, in that also the CT pulmonary angio. You've done everything, you are not finding the reason for severe hypoxemia. Then also then pulmonary embolism patient has been on bed, and there are reasons that this could be pulmonary embolism, then you get it. And immunocompromised patient with ambiguous finding on chest X-ray, you will not consider CT pulmonary angio, but you will consider CT.
So this was our index case, CT scan. It was done prior to presentation at the hospital. And this is showing patchy ground glass opacity with patchy consolidation in bilateral lung fields. So coming on to quickly, we are doing about the hypoxemic respiratory failure management. We'll not go into the details. So first is the oxygen, treating the underlying cause. For cause, we have to evaluate the cause of the acute respiratory failure and start management with the supplemental oxygen. Then we have option of non-invasive respiratory support in form of high flow nasal cannula and non-invasive ventilation. And if patient is not improving, we have options of invasive mechanical ventilation and ECMO, extracorporeal membrane oxygen. So now question is how to supplement oxygen in hypoxemic acute respiratory failure and how to choose between HFNC and NIV in hypoxemic respiratory failure. So oxygen supplementation will be discussed in the subsequent seminar.
You see, in this case, as we all know, it turned out to be influenza B. So what was the antiviral we used, Aman, in this case?
Sir, we upfront started oseltamivir before when patient was admitted, and we continued that.
Because this is very important point which I am making it up. If somebody has come within first 1 week is getting acute respiratory illness, our predominant is that we think in terms of influenza, and recommendation also from the CDC and other is upfront oseltamivir. If you're suspecting COVID, it gives you time to start antivirals. So you should wait for the results till you get it up. So that's what we did in this case. We use oseltamivir. But now because combinations have also been coming up, so once you have that advantage of multiplex PCRs have been to making, or now we have a combination of only COVID and influenza, that there you will use both remdesivir plus oseltamivir. And you can use Paxlovid, but unfortunately that was not easily available. But nevertheless, remdesivir, because this equation, we have been quite happy. Now let's come down to supplemental oxygen. Yes.
One thing which I wanted to add, it's very good. The first line, what is written, treat the underlying cause of acute respiratory failure. Most of the students, when you are taking Viva and other thing, they will oxygen and another thing, they will just rush on to this. This is you treat the underlying cause. Then management of respiratory failure. The first is the maintenance of the airways. Because you see this person, if is unconscious, then probably you will require ventilation right and day. Right? And then, of course, if patient can maintain airway, then supplemental oxygen, because that's also very important. Many of these patients are drowsy, like a hypercarbic respiratory failure patient who would require sometime intubation right in the beginning because he cannot maintain his airways. So that is the maintenance of airway, and then the breathing, which includes if there is a support required, then support and oxygenation. ABC, what we call it, of course, in any patients of failure, in fact. So maintenance of airway, particularly for respiratory failure, is also very important.
Let's move ahead.
Supplemental option, we have option of lower variable flow system and fixed flow system. Fixed flow system had advantage that it is independent of the patient's rate and depth of respiration, and we can monitor it better, like whether oxygen requirement is increasing or decreasing. So Venturi mask is a very good option to give oxygenation in emergency. Other option we have is high flow nasal cannula. So a patient present with acute hypoxemic respiratory failure, we calculate the PF ratio. If PF ratio is more than 150, we can give oxygenation by high flow nasal cannula. And if PF ratio is less than 150, the previous recommendation was to straight ahead go with intubation. But now, if you have adequate number of staff and you can monitor the patient, you can give them a trial of non-invasive ventilation. If patient has low effort, and this low effort can be indirectly estimated by if PaCO2 is more than 35 or in the absence of metabolic acidosis, but not the only factor. We can use HFNC or CPAP, and CPAP is preferred with an helmet NIV because we can give more PEEP with this helmet interface. Second is if patient has high effort, which is indirectly estimated by if PaCO2 is less than 35, not the only factor, we should give him pressure support ventilation. That is also preferably with an helmet than a face mask. But word of caution is that these require very close monitoring and need expertise. And if we don't have the current staff support or the expertise, the better is to intubate the patient.
Now, these are the guidelines, I think, which is very, very important. I think low effort and high effort, excuse me, we need to be clear. Obviously, blood gases is an important, carbon dioxide is an important issue. But remember one thing, if you find there is a sign of intercostal indrawing, sternocleidomastoid, trapezius, in other accessory muscles are overtly working, then that patient is not for high flow nasal cannula. Straight away, either if you want to use non-NIV, then it has to be either CPAP or BiPAP. But once that has been done, watch very carefully. If they don't do within 1 to 3 to 4 hours maximum, it's better to intubate and ventilate early. So it is very important when you're looking at it, please look at work of breathing at the bedside. The PSO2 supplements it. This is what is now accepted everywhere. And it was recently published in Intensive Care of Medicine. And we are presently surprised that we are also following the same pattern. But the key word is patient monitoring. At the first sign you are uncomfortable, patient is not doing well, it's no idea continuing ventilation, non-invasive or a high flow nasal cannula beyond 1 to 4 hours. Better prepare, intubate and ventilate. Dr. Chawla, any quick comment again?
No, see, I agree with you. I mean, pure hypoxemic respiratory failure, we used to use non-invasive ventilation. And as the 150 figure of PF ratio, once it is less than that, probably one should ventilate these patients, and you could give a very brief trial if it is effective. And now with hypoxemic HFNAC, because you see the problem with all the oxygen therapy, whichever we have, they were not giving high flows. So HFNAC, because patient is breathing at a rate of 60 and you are giving 15, 20 liters, which was not. So patient used to appear very tachypneic on that. So that has been overcome by the HFNAC. It gives high flow. And when you give high flow with your normal oxygen therapy, you can't humidify. So you can humidify. That's why it gives little PEEP also. It replaces the dead space with the flow, the oxygenation. So it eases out the breathing in that patient. So because of these, HFNAC has now, and there are a lot of studies, and they have shown, although the meta-analysis show that it is equivalent to NIV, but HFNAC is now preferred because of the 2-3 major studies which had shown. And as a first line in hypoxemic respiratory failure, patient who can maintain and his PaCO2 is within the normal range. And then as the PaCO2 rises, then probably you could give NIV, or the PaCO2 is high. Initially, the NIV would be a choice. And as Dr. Dhruv said, whenever you give in these low PF ratio patients, HFNAC or NIV, you must decide when to intubate these. There are a lot of scores have come up, which are also used to decide, to help to decide that he's going to talk about these scores, that when to intervene. But you should not wait beyond 4 to 6 hours, because one of the major reason which we've seen during COVID and otherwise also, but because the saturation is maintained with this NIV, and you keep on delaying intubation, and delaying intubation, all the studies have shown it increases mortality. If your patient is not comfortable, if your parameters are not being met, then you must intervene and intubate. Intubating, treating the primary cause, and then you would be able to extubate them also early. So that's all I want to say.
Yes, Aman, yes, please.
Next question would be, how do we monitor this patient who we have started on HFNC or NIV? So we have to do the monitoring, and we have some supplemental scale that can guide us. So primary clinical monitoring should be done in all cases with primarily focus on the respiratory rate, oxygen requirement, flow or pressure requirement, which indirectly will tell you the work of the breathing, signs of the fatigue, and this may be supplemented by the blood gases. Then we have two scale, the Hackor scale and the ROX index. This Hackor scale is been tried in both NIV and HFNC, whereas ROX index is primarily for HFNC only. The Hackor stand for the heart rate, acidosis, consciousness, oxygenation, and respiratory rate. And the maximum score is 25. The less than 5, if we get after 1 hour of giving any intervention, NIV or HFNC, it is associated with low risk of therapy failure. With ROX index is calculated by dividing SpO2 divided by the FiO2 into respiratory rate. And the study have shown that if we take ROX index 6 to 12 hours after HFNC and it is less than 4, and it is a predictor of treatment therapy failure. The issue with the ROX index is that we have various cutoff according to the duration and the time it has been used. So this each hour we don't have a value to decide, like 30 minutes or 1 hour. Every has a different ROX index cutoff. So it makes it a bit difficult to use this index.
You see, it is a ratio of FI2 to respiratory rate. It is not multiply. Therefore, as the respiratory failure worsens, the tachypnea happens. That's why you have a variability which happens. It is not into RR. It is actually slash RR. So it's a ratio to SpO2 FI2 to respiratory rate. I think that's a typographical error. Yeah, rest is what we have been following. We have recently published our data from Rohtak in Monaldi in chest diseases, where we have shown it that probably if it's around, but usually we take 4.78 or so. So 4.4 is a good enough predictor of failure or success. So we have been monitoring every RD, and it's a non-invasive method. It's a clinical method. So even same is true for HACON. So there is no replacement for your clinical evaluation of the patient. That is the bottom line. So you please evaluate your patient. Look at the respiratory rate. We keep on looking at the monitors. Please pick up the pulse, fill it up, and then see what is happening. And also look at what is happening to the accessory muscles of respiration. So you take these multiplex things together to take a call. And as Dr. Chawla also pointed out, it's better to intubate early whenever in doubt rather than continuing with it. I think that's all I want to say. And we move ahead.
This we have already discussed. So we move on to case study 2. This is a 62-year-old gentleman who's a smoker with smoking index of 350. He was on ICS LABA-LAMA triple inhaler therapy. He presented to emergency with chief complaint of breathlessness for past 7 days and drowsiness for past 1 day. On examination, he was conscious oriented, and his saturation was 82% at room air with pulse of 98 per minute, respiratory rate of 18 per minute with use of accessory muscles. There was flapping tremors were present, and on examination, he had barrel-shaped chest and bilateral rhonchi was present. So ABG done at the time of presentation showed pH of 7.25, which is low, and PCO2 was 74 high, and PO2 was 59 with bicarb of 31.9. So now question is, how do we interpret this ABG and what is the type of respiratory failure? So for ABG interpretation, the patient has a low pH with high PCO2 suggestive of respiratory acidosis, and PCO2 is increased. So this is suggestive of acute on chronic type 2 respiratory failure. And if we calculate A gradient in this patient, it is coming out as 2. So this is the approach to type 2 respiratory failure. If the patient pH is high, PCO2 is low, and bicarbonate is normal, this suggests the patient has acute hypercarbic respiratory failure. If the same setting, patient pH is low, PCO2 is high, and bicarbonate is also high, this is suggestive of acute on chronic hypercarbic respiratory failure. And if pH is normal, PCO2 is high, and bicarbonate is high, it is suggestive of chronic hypercarbic respiratory failure. So next is approach to type 2 respiratory.
Any comment, please? Dr. Chawla, sir, any comment?
Yeah. No, I think this is fine. I mean, whatever he said, but usually, you know, when you interpret ABG, if you see all these three things, it will give you a brief idea what's going on in the patient. Because if patient presents with a normal pH, high PCO2, high bicarbonate, you know, this is going on, then the problem, why a patient has presented to you, you need to look. Why the patient has come to you? Why is it the increase in spasm, or what is happening to that patient? And if patient appears with a pH being low, you know that the patient requires very urgent attention, because it also tells you the severity of acute presentation. But otherwise, this is all right. No comments so far.
So next we move to cause of the type 2 respiratory failure, predominantly being the hypoventilation, which may be because of sedative obesity hypoventilation syndrome, dead space ventilation that we see in obstructive lung diseases due to VQ mismatches, and neural and neuromuscular weaknesses, which can be due to myasthenia, Guillain-Barré, OP poisoning, and kyphoscoliosis commonly seen in our...
My comment here is Pawan. Pawan. Aman, you go back to alveolar arterial oxygen gradient calculation.
Yes,
Because we should not send a wrong message here.
yes, sir.
Now, how have you calculated alveolar arterial gradient?
Yes, sir. So the FiO2 is this 150 minus PCO2 by bicarb. So 150 minus 75 will...
You see, if you have 0.21 into 7, this is on the room here, you will calculate, na? कितना है तो उसमें कितनी होगी तुम्हारी alveolar कितनी होगी oxygen?
हाँ sir, this alveolar is 150 minus PaCO2 by respiratory quotient.
And what is it?
So it is coming as 150 minus this.
Because you cannot have a normal one here because this is not a primary hypoventilation.
Yeah, this FiO2 actually multiplication is missing.
Yes, that is what I am saying. So that is why it is wrong.
Yes,
therefore, there is an increased gradient. So
yes,
if you see it here, Fi 2.21, and in this case, if 700 is there, that you have calculated up here.
Yes, sir. Either I forgot the FiO2 multiplication.
Yes. So that is what I'm saying. This is wrong.
Yes, sir.
So we have to be very careful. It cannot be normal because this is a ventilation perfusion mismatch.
Yes, sir.
So you will do one thing, one we will be discussing, you will calculate and put it up. Go ahead.
Yeah. Lastly, we can have increased carbon dioxide production because of the increased metabolism, as in septic shock, thyrotoxic crisis, or malignant hyperthermia. So next question would be how to supplement oxygen in type 2 respiratory failure, and what is the role of non-invasive ventilation in type 2 respiratory failure. So oxygen supplementation, the preferred mode as advised by the NICE guideline is we should give oxygen by the Venturi mask, as it is, we have already discussed, it is independent of patient rate and depth of respiration. Patient may get the desired FiO2 and it can be easily titrated. Second is the target saturation should be between 88 to 92%. So role of non-invasive ventilation in type 2 respiratory failure. So any patient of COPD or with type 2 respiratory failure having pH between 7.25 to 7.
You see, I just want to tell our audience is that then the patient of type 2 respiratory failure, primarily with the chronic lung disease or with the chronic like kyphoscoliotics, or they have a chronic neuromuscular ventilation, when they come up, be very careful in terms of oxygen supplementation. Because one has seen when the residents use the oxygen in the emergency, suddenly patients become extremely hypocarbic and they were conscious, become unconscious. So please, when the patient comes up there, start with the low oxygenation. Always good is to start with Venturi, which is a type of a high flow fixed delivery device, rather than simply with your nasal prongs. Beyond 2 to 3 liters, you can actually give up to 80 to 90%. We don't realize it. And the reason for this is it worsens VQ mismatch, one. Secondly, you have hypoxic drive goes away. And third is we see that the release of carbon dioxide reduces in the presence of oxygen. So what we called as a Haldane effect. So this combination can lead to it. If you have done so by mistake, then don't remove the oxygen. It's better to ensure shift over to non-invasive ventilation to give adequate oxygenation. That is very important. Because commonly, Dr. Chawla and Dr. Gyanendra, you must have seen in the emergency, it's a very, very common problem which we encounter.
Correct.
So that is called titrated oxygen therapy, and rightly said. And one must always monitor the SpO2 while they're giving oxygen therapy. So preferably in patients who have got hypercapnia, the oxygen saturation shouldn't exceed more than 94%. For that matter, even in hypoxemic patients, hypoxemic respiratory failure, the target SpO2 may not exceed 96%. In majority of patients, there are only 4 or 5 conditions where high FiO2, upfront high FiO2 oxygen therapy is indicated. Otherwise, lower the better in almost every patient, whether it is type 1 or type 2.
In these cases, we always say 90 plus minus 2. That's how we move ahead with it. But nevertheless, as you have rightly said, I agree with it, that we need to be very, very careful about it. It's a very common challenge and the problem which we see. And I'm sharing it with my experience, and I've been telling all the time, be very careful while reoxygenating these patients, and arrhythmias are not uncommon. If you remove oxygen, you'll end up with the trouble. So first, please.
At this moment, sir, just for the benefit of residents, there are very few limited indications of high FiO2 oxygen therapy. I'm sure we'll cover up in the oxygen therapy part also. But pneumothorax, suspected air embolism, carbon monoxide poisoning, and then rare causes like sickle cell crisis and cluster headache. So very few conditions where high FiO2 oxygen therapy is indicated. Otherwise, in majority of the patients, it's always low FiO2 oxygen therapy with a venturi mask, which is a fixed delivery device system.
Another golden rule here is in continuation of, if your need of requirement is more than 0.3% on FiO2, please look for an alternative cause in this, whether it is a pneumothorax, whether it is a pulmonary edema, whether it is a pneumonia. Simple, plain COPD usually oxygenate very well. So if you remember, if we remember that, we always make lesser mistakes. Chaliye, please.
So this A gradient is 41, sir, calculated. That was. So coming on to the role of non-invasive ventilation. Sir, 41.
So it is high.
Yes, sir.
Okay, na?
Yes.
That's the message. So wherever you have ventilation perfusion abnormality, it has to be high. So it should have raised a question why it is normal. Primary hyperventilation is the only place where it will be normal, not otherwise. Let's go ahead.
Yes, sir. Coming on to the role of non-invasive ventilation in type 2 respiratory failure, that is respiratory acidosis with pH of 7.25 to 7.35, and this pH is not pH below 7.25 is not an absolute contraindication, but patient require close monitoring, and consciousness is the parameter we look forward to giving NIV when patient pH is between less than 7.25. Second is hypercapnic respiratory failure secondary to chest wall deformity, that is scoliosis or thoracoplasty, which is now rarely seen, and neuromuscular diseases. And third absolute indication is cardiogenic pulmonary edema, to whom we have given CPAP and he is not responding to CPAP therapy. We can give them trial of BiPAP therapy.
There is another indication, acute decompensation of obstructive sleep apnea and obesity hyperventilation syndrome. Yes, that is because you will never get studies, because you can't have a control in that now, because it's a well accepted modality for the management of OSA and obesity hyperventilation. So acute decompensation, although the evidence will never come, because many years we have been, all of us use in that condition. So that's also indication in hypercarbic. The maximum evidence for the use of non-invasive ventilation, whatever our experience is in COPD patients. Even in the chest wall deformity, very few studies are done. And asthma, hardly 2 or 3 very simple studies. And the asthma, they have not found it to be that useful as in COPD. So COPD, chest wall deformity, and the decompensation in obstructive sleep apnea and obesity hyperventilation syndrome. In cardiogenic pulmonary edema, only if a person has a hypercarbic variety. Otherwise, CPAP is a modality of choice, not the non-invasive ventilation.
Very true, sir. In fact, the combination of OSA and COPD we called as an overlap syndrome. We did a study at Rotterdam and we found, which was consistent with the international data, roughly 10 to 15% of your patients actually will be having an overlap syndrome. So I think it is very, very important. And that is where the blood gases are extremely important in terms of whether it's an acute hypercapnic failure or it is an acute on chronic hypercapnic failure. So if you are having an acute on chronic hypercapnic failure, what Dr. Chawla said holds absolutely true. Yes, please.
So the relative contraindication of non-invasive ventilation is if patient has impaired consciousness, patient is having severe hypoxemia, the chances of failure are very high. And if patient is having copious respiratory secretion, which will be very difficult to drain with a mask on. So in this indication, it's better to intubate the patient than giving an NIV trial.
In fact, same are our guidelines also of the Indian Society of Critical Care Medicine, which myself and Dr. Chawla have been the part and parcel of it, and we wrote it under his guidance. He's the chief one. I think that they are the same, actually. Yes, please. How to assess NIV?
How to assess NIV failure? So, as I have already discussed, that clinical and lab parameters, they can guide us. The respiratory rate, oxygen requirement, pressure requirement, signs of fatigue, change in consciousness, blood gas, which may be showing the fall in pH or rise in PCO2. And Hecor scale has been validated for NIV also. And previously, I've told you the value. It is less than, if it is less than 5, then the risk of failure is low. So,
another important thing we should remember is ROX index is not validated for your NIV. That is for HFNC. So do not extrapolate it as of today unless and until it's a part of a study. Yes, please.
So last is when to intubate the patient with type 2 respiratory failure. So if patient is having apnea, reduced level of consciousness, which may be used, GCS may be used if it is less than 8, rapid change in mental status, or any previous airway injury or airway compromise, high risk of aspiration or hemodynamic instability, this patient should be intubated. Last is the role of...
Before that,
Yes, sir.
One of the very important thing when you intubate these patients, always there are few precautions. You should try to intubate with the widest endotracheal tube possible, because many times the person taking off or weaning off becomes difficult if you have used a very thin tube. And only during intubation, you should use sedation and paralysis. If you are not able to ventilate without paralysis and high sedation, then you should paralyze, because many patients are paralyzed and sedated for a long time, and then weaning off becomes difficult. So when you intubate these patients, little expert persons should intubate these patients as well as asthmatics. You should use the widest possible, at least 8-number endotracheal tube you should use when you intubate these patients.
And sir, another important thing is quite often what I have seen is you need to adequately oxygenate them before intubation, because when you put a laryngoscope, a fair number of them in the early phases, when without giving adequate oxygenation, they go and arrest right at that point of time. So stabilize it. Once you have stabilized, then oxygenate and then intubate, as Dr. Chawla has said it. And which is very important is, once you have intubated it, again, the learning point is that blood pressure may fall. So very important is when you put a tube in, when we will discuss ACOPD, do a gentle bag and look at it. There is no marked raised intrathoracic pressures. And secondly, the cardiovascular stabilization also takes place. So autopsy, we need to look at it. So always do, once you put a tube, a small bag ventilation and a lower rate and stable, and then put the patients on ventilator.
Dr. Dhruv, I can remember at least 10 patients who have died after intubation. Because if the patient gets sick middle of the night, he's intubated, and usually the emergency persons and the persons who's intubating, they will keep on bagging at a very high speed because patient is desaturating, and in that process they create dynamic hyperinflation. Of course, as you said, the hypertension, and many of these patients get pneumothorax and arrest. So, whenever in my life for last 20 years, I ask somebody to intubate, there are 3-4 instructions I always give. I tell them, when you intubate, do not bag more than 10 per minute. And I tell emergency people here also, count 6 and then bag. Because, if you keep on begging like this, hypotension 100%, and many of these patients can get a pneumothorax. So they should, as Dr. Dhruv also said, that you should keep a low rate, not more than 10 with a bag mask, because initially the catastrophe occurs initially only. So count 6 and then bag. Don't worry, your saturation is low. Saturation is coming 60. It makes you panicky. Once your tube is inside, patient is not going to die, I can assure you. So you bag not more than 10 times with a very small volume. And you ventilated, you are settling, patient will settle down because you have to treat the primary reason for the bronchodilator, steroids. As they act, the things would improve. So you do this because it's very, very important when you intubate these patients. All these precautions should be taken.
So bottom line is primary management of primary disease A, when oxygenation 2, then you support them with the NIV. If it doesn't work, you go to invasive ventilation and take all these precautions. And now, earlier we used to be very nihilistic. Now prognosis is reasonably good when you ventilate actually COPD. Most of the time they come up. We will discuss during AECOPD the weaning challenges which we do face. Yes, next please, Anand.
There are some indication where this emergency tracheostomy may be required. And this is required mainly when we have upper airway obstruction or patient who have failed enterotracheal intubation, which may be because of foreign body, because of angioedema or anaphylaxis. In this situation, to secure an airway, emergency tracheostomy may be required.
In this case, I would like to add one thing. You have an angioedema, you have anaphylaxis. Again, that leads to angioedema and vocal cord, and people are in a position, cannot intubate, cannot ventilate. So the procedure of choice, there is a cricothyroidotomy. If that is not available, then it's emergency tracheostomy. But nevertheless, this is something very important, especially anaphylaxis in emergency medicine. Similarly, angioedema because of any drug, or what we use also in old time to cause, like Dr. Chawla, if you remember, is acute asphyxic asthma. So there you used to stop straight away adrenaline. But otherwise in these conditions, a cricothyroidotomy, if that is, you are not having a challenge or a difficulty, to go for emergency tracheostomy, and they can cause sudden death and the foreign body aspirations if they happen. That is the thing which you need to look in foreign body. It is a Heimlich maneuver which you do, but nevertheless, if that is not working it out, you need to take care of it. Any comments, sir?
No, I think fair enough. Go ahead.
Next, please.
So this was the last slide.
So the take-home message.
Take-home message. So any patient presenting with a...
Sorry to interrupt, Dr. Aman.
Yes,
Just one very simple question, but I think which we as students had the same things. What should be the target saturation in patients with hypercarbic respiratory failure, acute or chronic, and also in patients with severe pulmonary hypertension? This is the question. Target oxygen saturation.
Severe pulmonary hypertension.
Yes, sir. Both. He's asking both, whether in chronic and acute respiratory failure, along with severe pulmonary hypertension.
Like Dr. Dhruv says, 90 plus minus 2. That is your aim of saturation. And one of the problem is that you can't leave these patients unattended. Once you fix up, your oxygen requirement is high, but as you give bronchodilator steroids, suddenly you will find the saturation is showing 100. So you need to instruct to the sister that she has to keep it between 88 to 92. Because initially the oxygen requirement may be high to maintain that. But as after a while, sometime even within 2 hours, she has to... So instruction should be very clear to the sister that she has to maintain between that, whether it is required to decrease or increase the saturation. So this is very important.
The chronic hypoxemia, Dr. Manjunath, the question which was there is, as Dr. Chawla said it, I said it earlier also, it is very clear. We don't overdo it. Keep with the minimum possible. Keep it around 88 to 90. That's good enough in these cases. And if it is an acute hypoxemic failure, try to keep it between 90 to 94, because oxygen is a drug. It may be a gas, but it is a drug. It's a gas drug in the form of gaseous. It can cause its own toxicity. Therefore, you try to do it, except People have a head injury, people have a seizures, people have other things which are there. You may need to keep it otherwise. But in a simple, straightforward case, don't exceed. I will rather say don't go beyond 90-92%. That's the
I will tell you, Dr. Dhruv, even in hypoxemic respiratory failure, who have a pure hypoxemic, I don't like to keep them higher, because you see, if you keep 92, 93 saturation, if patient gets better, you come to know. Patient gets worse, you come to know. If you are keeping it 60, you are not getting ABG repeatedly. If you're keeping 96 or 98, by the time the PO2 falls, it is already very late. I mean, the patient might be deteriorating for last 7-8 hours and you come to know now. But if you're keeping it about 93, if patient deteriorates immediately, that there is something wrong happening to this patient.
Sir, another important thing is which our dear residents must know, and we all should be aware about it, that the pH has a lot of impact on the saturation. If you are having acidosis, your PO2 may be very high, but firstly, SpO2 will be low. You are having an alkalosis, you will be having high SpO2, PO2 may be low. It is because of the oxygen binding and later on affecting the saturation. That we will discuss in the next edition on oxygen therapy. But remember one thing, these metabolic challenges can alter how you see it on pulse oximetry. That is where the problem is. But nevertheless, if you keep, as Dr. Chawla said, around 90-92, 88 to 90, you are fairly stable. If I'm having 88 with a pH of 7.2 or 7.3, in fact, it is more than what is desired. Therefore, please go with it. There is a concept of permissive hypoxemia, which we'll talk in ARDS, ALI when we'll discuss it. But nevertheless, less is good, less is more. That is the principle today. And don't overzealously do, because you may cause lung damage secondary to hyperoxia or by delivering more to the lung. So we all know oxygen toxicity is causing and contributing to the ventilator-induced lung injuries or otherwise also to the patients.
Dr. Manju.
Thank you, sir. Yeah, thank you, sir. That answers the question. I think, Dr. Aman, you can continue with the take-home message.
Yeah. Take-home message would be to always carefully take the history and examine the patient. Patient will give the all signs of the respiratory failure, and history and examination will guide towards the etiology of the respiratory failure. Pulse oximetry, arterial blood gas, and chest X-ray per se is mandatory to diagnose the respiratory failure. For the cause of the respiratory failure, other investigation may be required and can be done as needed. Oxygen supplementation should be done, and NIV and HFNC can be used. But whenever we are using an NIV or HFNC, very close monitoring should be there. And any scenario, if we are in doubt, better to intubate the patient, avoid any delay in intubation and mechanical ventilation for better outcome.
Thank you, Aman. I think this is very important for us, that these are the fundamentals. Pulse oximetry has redefined the things. Arterial blood gas is to supplement it. But whatever you're doing it here, primary cause treatment is mandatory. Rest, everything is a bridge therapy or the consequence of the primary etiology leading on to physiological maladaptation to an extent which is presenting to us as acute respiratory failure. And finally, one clinical sign is the key in critical care, and more so in respiratory medicine, is respiratory rate. I have seen it to be underused. We all look at PM, pulse rate, BP, but please look at respiratory rate. If it is stabilizing, it is falling, it is stabilized, you are sure that yes, person is doing well and is stable. Dr. Chawla, please, your final comments.
You said, I just want to say one thing. As a chest student, we have inspection, palpation, percussion, and auscultation. And I think now the time has come, ultrasound should be the fifth, because it can really narrow down the diagnosis and treatment could be faster. But of course, it has logistically, it is difficult probably as of now, but as the time passes, I think ultrasound machines may become very small, and we all may have a small machine in the clinic as a part of. What I'm trying to stress is that Now it is mandatory for differentially diagnosing a condition in your hospital as a physician, as an intensivist, to learn yourself the art of doing, because it does not involve much of the training. With little training and courses, you could do a good ultrasound and diagnose condition quickly rather than waiting for the CT scan or other things. So this is extremely important, because pneumothorax, your X-ray may not show, but if you are good at ultrasound, very small pneumothoraces, sometimes missed on chest X-ray, but this can detect. So this is very important. Rest of the points, I think whatever it is said. So history is very important. You should never forget the primary cause of the respiratory failure. Try these pulse ox, ABG, and chest X-ray, of course, are must. And the rest of the investigation should be on the case basis, because whatever you start as a student will become your habit lifelong. Because if you start writing everything right in the beginning and big investigation, this will become your practice. So practice the clinical science, restrict your investigation, what will give you information, and then know about oxygen supplementation, HFNE, non-invasive ventilation, when to use and when to not to use, and stop and convert them into intubation. And then I think this is a process which one learns. We've been learning every time. And I have learned today also from my friend and colleague, Dr. Dhruv and Dr. Gyanendra. And thank you very much for this.
Thank you, sir. Thank you very much.
Gyanendra, any comments?
Thank you.
Dr. Gyanendra.
Sir, just a short, quick, especially for our residents. I can see 5 of us on the screen. So something about 5. Fifth vital sign, there are many contenders for fifth vital sign. I am sure the pulse oximetry will win that. So pulse oximetry is the fifth vital sign. 5 important causes of acute respiratory failure, which we, again, just to re-emphasize: pulmonary edema, ARDS, pneumonia, pneumothorax, pleural effusion, and acute exacerbation of COPD. Then 5 common causes of type 2 respiratory failure. If we just keep in this mind, we'll not miss majority of the things. So again, COPD, acute exacerbation, for that matter, any other advanced structural lung disease, obesity, hypoventilation syndrome, and neuromuscular diseases. And lastly, about 5 indications of upfront high oxygen therapy. Otherwise, it is always low oxygen therapy, or for that matter, titrated oxygen therapy. So 5 causes of upfront high FiO2 oxygen therapy: pneumothorax, suspected air embolism, carbon monoxide poisoning, sickle cell crisis, and cluster headache. So this is just for our resident colleagues. I'm sure we had a nice discussion, and I also learned a lot from you all. Thank you. Thank you for including
me. Thank you, Gyanendra. Dr. Manjunath.
Thank you, sir. And just before conclusion, one short question. Any target saturations in pregnant cohort, sir?
Pregnancy, you keep higher ones, because you need to take care of the 2 lives, not 1. Not that because of that you need an additional thing, but because you have to contain and maintain a very high oxygen delivery system, because the the hemodynamics are such that you need to keep it high. Therefore, that is one place. If pregnant female is come, I would like to keep 94 to 96 rather than 92.
Thank you, sir. Thank you.
That
brings us to the conclusion, and we are also short of time now. We have only few more seconds left. And I thank our honorable panelists for their extremely wisdom-filled words, which are very helpful in understanding the day-to-day process. And again, they have stressed that clinical examination is the key rather than just blanket investigations. Thank you, sir. Thank you, Dr. Rajesh Chawla. Thank you, Dr. Gyanendra Agarwal, for your inputs to this one. And as usual, Dr. Dhruv, reading between lines is always important in clinical scenarios. And thank you very much for your words, sir. And not last but the least, Dr. Aman, you did a good job by presenting in a systematic manner. Thank you very much. And next session will be next month, first Sunday, which will be regarding oxygen therapy. We will be coming up with again the stalwarts in the field and presentations being done by the residents from different institutes all over India. And I think we will get back to you with the link and all those things. Thank you very much.
Feedback is very important. Please tell us how can we make it better and improve it also.
Yes.
Thank you.
We will be waiting for the feedback.
Thank you, Dr. Chawla. Thank you, Gyanendra. And Manju, thank you so much.
Thank you,
Thank
sir.
you.
Thank
Thank
you.
you, sir.
And thank you, IS and Dr. Talwar, and Glenmark also for providing the support. Thanks a lot.
Thank you.